Hey guys, I'm really sorry that the lecture didn't record in good quality. Live and learn. We are really trying desperately to learn that. You'll find that this recording, of course, will be a little bit shorter than listening to the 4 hour lecture because I don't have any interruptions and I can carry on without having to stop too much. So I'm going to go ahead and record this so you will have a good quality recording. So let's get started with this. I'll take my face off first. Okay. This is what I gave you guys for a study plan, study guide, instead of PowerPoint. I was trying to get everything together so you could make sense out of this. Your book goes through several pages that shows you how each body system's affected. And so what's important to know here, the concept of this, is that musculoskeletal dysfunctions are going to affect all of your body systems. So don't just think when you have somebody that comes in a cast, broken bones, traction, anything like that, it's not just about the musculoskeletal part. We have to be sure that we are addressing all these other issues. This would be your clinical significance of somebody who came in a spica cast. You would have clinical significance that affect the metabolic, cardiovascular, clinical um, significance about how this is going to affect your respiratory, what you should be watching for, what your nursing interventions would be, and so forth and so on. So let's see what happens when we have musculoskeletal damage with a child. Of course, a lot of this will bleed over to adult. So there's some things that we're not going to cover because Miss Smedley's going to cover. But there's no point in us taking up a bunch of your time doing things that are not specific to children in the children's portion. So with these injuries, we have the decreased muscle strength, of course, and tone and endurance. They're not able to do much. Their muscle strength is lost. They have atrophy of the muscle. When they have atrophy of the muscle and possibly um, and of course, as I said, it affects the rest of the systems. When we have atrophy and decreased muscle tone, we're going to see DVTs develop. Bone demineralization is a big one, that our bone is going to demineralize, and when it starts demineralizing, what's going to leach out of the bones when it starts to demineralize? Well, our calcium is going to leach out of the bone. It's going to go into our vascular system, which if you look over in the metabolic side, it says hypercalcemia is something we have to watch for. So this is one of the reasons why we watch for hypercalcemia, is because of the demineralization of the bone. Catabolism. This is the breakdown of protein in the body instead of breaking down protein ingested. So this would be taking muscle and actually breaking it down for protein for use in there. So that's going to cause us to have a negative nitrogen balance over in the metabolic side. So that's how these lead up to those things. And of course, another thing that bone demineralization can lead to up to is osteoporosis, because we're losing all the calcium and minerals out of the bones. So some of the things that we need to be looking for when we have just to treat the musculoskeletal disorder, we need to be putting some things in our nursing interventions, such as if we want to prevent the DVTs, we should use the anti-embolism stockings or the CSDs. So sequential stockings, we should be using those if we got someone who is on traction in one side and the other leg's fine. You can put CSDs on there and stockings. Anytime you have a child, you need to have activities that's going to use those uninvolved extremities, because that's how children get rid of anxiety and anger. They have to be very active. So if their leg is broken and it's in traction, then they can still use their upper body. So they can still. So you need to plan play activities that will be appropriate for their age. Always appropriate for their age. So you've got to know your developmental stages. You can do active range of motion, passive range of motion. Get them in there doing those isometric. Um, the isometric's not going to help with bone strength, but it's going to help with muscle strength, and muscle strength does help us develop our bone strength. And then the active and passive range of motions is going to keep us from having contractures and joint dysfunction and keep us more active. So that, children need to have that because they're still growing. We can input splints. If it's we want to try to prevent contractures, we can put splints on there. Be sure we're maintaining body alignment. We can do breathing exercises. That's going to help us over there in respiratory. We can have them blow bubbles, blow a pinwheel, things like that that would require them to, take a deep breath and hold it, blow it out, things like that. They should always be on a high calorie, high protein, high fiber, and low calcium diet in most cases. You'll always find one case that the doctor may say we're going to change this, but for our purposes, high calorie, high protein, high fiber, low calcium. Always handle those extremities carefully, especially if they've just been casted, because the cast may be wet. You should handle that with the palm of your hand. We may need to give them calcium mobilizing drugs, and of course, always be sure we keep them hydrated well. So our metabolic cardiovascular, let's look and see how musculoskeletal disorders are affecting that. We get a decreased metabolic rate, and then that negative we get the decreased metabolic rate from inactivity. We get that negative nitrogen balance from the catabolism of the protein in the muscle. We get hypercalcemia related to the demineralization of the bone. So how does that affect the rest of the body? Well, you all know that when we have decreased metabolic rates, it causes a slowing of the body system. So we start seeing we don't want to eat as much. We don't even want to breathe as much. But we definitely see a decrease in food intake, especially in that protein. It's hard to get kids to eat a lot of times things that are good for them, but they don't like. And we're trying to get them to eat things. And that negative nitrogen balance, of course, if we don't have enough protein in the body, it's going to impair the healing. If we're breaking our body down to run our body, we're certainly not going to be able to heal it. Hypercalcemia, we've done talked about, because they can't reabsorb it from the blood once they do that. And so we have that electrolyte imbalance going on. And what does hypercalcemia cause with our cardiac? So we're going to have some hypertension going on, maybe. We're going to see some issues with our heart rhythms. Of course, it will affect the heart muscle. And then we are also going to see some orthostatic intolerance. You can see hypertension simply because the heart's having to work harder. We can see syncope when they try to get up or sit up. You may even see hypotension from the orthostatic hypotension. We have decreased cerebral flow, and when we have decreased cerebral flow, what happens there is that you're going to have a little bit of inability to think clearly. Kids may not be as responsive or as bright as they were because they're having a little bit of decreased cerebral blood flow there. Tachycardia. You may see tachycardia even though they have a decreased metabolic rate. It's going to increase the workload of the heart, and then of course we can have possible blood clots and certainly edema in there. Now, the nursing interventions that we should do serum calcium levels. Well, let's just float right down here. Small, frequent feeding is real important. Kids don't want to eat a whole lot at one time, but we need to get a lot of calories in them. So, offer them snack-like foods that they can eat in small amounts at a time. Try to make sure it's high calorie, high protein. I said in my lecture something about, kids like milkshakes, but milkshakes really aren't good for them because they're made of, have a lot of calcium in them. But if you can't get the kid to eat anything else, you're going to have to weigh the benefits to the risk of, do you want to have the risk of developing hypercalcemia, or do you want to make sure that he's able to heal quicker? So basically, whatever you can get your kid to eat. If they like chocolate cupcakes, give them chocolate cupcakes often. But, you can put protein powder in those cupcakes. Protein powder is very easy. You can buy a big container of that and you can put it in almost any food, and they can't really tell it's in there. Like you can put it in spaghetti sauce, things like that, just to increase the protein that they would get. How would we treat this with babies? Well, babies, we can increase their formula calories. We have the regular formula for babies. There's 20 calories per ounce. They make a 22 calorie and a 24 calorie per ounce formula, and you have to have prescriptions to get that. For breastfeeding moms, they have breast milk fortifier so that mom can pump and put this fortifier in the breast milk that she feeds by bottle. Lets dad do the feeding there so they can have some bonding time going on. I had to throw that in there. So we want to monitor their pulses, especially their peripheral pulses, especially distal to their fracture site, blood pressure, and of course always for the pulmonary edema. So let's move over to respiratory. They develop a decreased need of oxygen simply because they have decreased chest expansion. If they're immobile, they're not active, they're not expanding their lungs very well, they're not using their abdominal muscles that helps with the diaphragm contraction, and they could very well develop pneumonia, atelectasis, and a lot of times upper respiratory infections. So these things in respiratory can be developed from them simply having fracture, or being in traction, or being in cast, being immobilized. So these are things that are clinically significant for us. Some of the things we can do is encourage that deep breathing, such as taking in a deep breath and blowing it out. For child appropriate age, you might let them blow up balloons. You certainly wouldn't want to let a toddler have a balloon to blow up. For one thing, they don't have the air to blow it up. For another thing, they might swallow it. So you definitely don't want to do that, but you could blow bubbles with a toddler. You could do the pinwheel with a toddler. Make sure they're in an optimum position for breathing. You want to have them as upright as you can without getting their traction or in disalignment. Always monitor for signs and symptoms of inadequate breathing. Check their capillary refills. Be sure that you're listening to their lungs, and be sure that you're checking to see if those lungs are expanding, doing your assessment on lung expansion. Be sure you're doing all these nursing interventions to help care for possible respiratory. And of course, it just kind of stands to reason if we have a slow metabolic rate and we have immobility, we're going to have problems in the GI. They're going to get distension from not being active and not being able to pass gas out. They're going to become constipated because they don't have that activity. The GI system has slowed down, kind of like when you're pregnant, everything slows down. Well, things are slowing down in the GI here. And then, of course, there's difficulty feeding because if they're constipated, they're not going to want to eat. If they're distended with gas, they're not going to want to eat. And so they'll have difficulty with this. So things that we need to make sure that we're doing is monitoring their bowel sounds to be sure they've got good active bowel sounds. Small meals instead of large ones, and we should make sure that they're getting a lot of fresh fruits and vegetables in there for high fiber, as well as you can add fiber to their diet and sneak it in where they won't know it's there. Bowel training is a really good thing that you can do. Is you can take take them to the bathroom. If you know your child real well, you know when they go to the bathroom. Most children have a certain time of day they go to the bathroom, and you can just pick that time and take them to the bathroom if they can go to the bathroom, or you can place them on the bedpan. There are, if they're going to be in long-term traction and they're able to be gotten up once or twice a day, there are special commodes that you can have made for these kids. Stool softeners are always a good thing to give to kids that are immobile, as well as making sure that we are giving them adequate fluid intake. If they don't like to drink water, there's Kool-Aid that's sugar-free Kool-Aid if you don't want them to have a whole lot of sugar. Um, You don't want to give them a lot of caffeine drinks because that has a diuresing effect, so you don't want to do that. You want to give them drinks that are going to hydrate. Some of the sports drinks, that they kids think they're really special when they get to drink, big sports drinks. So those are some things you can do, and things that like Jello and popsicles, things that are considered liquids but are in a frozen form, which they would love to probably eat or uh, to drink. So those are some things we can do for the GI. And I put urinary and integumentary together because they were both short, but that doesn't mean they're not important. In fact, they're probably where you're going to see a lot of your problems at the very beginning. They're going to have trouble voiding because they can't stand up or can't sit down on. They have to use a bedpan, and that's going to be unusual for them. Now, when you got children in diapers, this is usually not a problem. But if they have problems in voiding, then they're going to have urinary retention. And if they develop urinary retention, they're going to develop urinary infections. Without adequate hydration, they're also going to develop renal calculi, especially because you're trying to get all that calcium out of the vascular system. Is going to go through the kidneys, and if there's a whole lot of it going in there, the little calculi can form from calcium. So these are some things that you really want to watch for. So we're going to check for decreased circulation, pressure spots on their, and be sure that we keep them clean and dry to make sure that they don't have problems with their skin. And then we're also going to position them every couple of hours. You can actually massage the areas of healthy skin to keep them from breakdown, to make them toughen up a little bit. You can assess where the cast meets the skin, and you can put tape around it, which is called pedaling. And Miss Smedley's going to go over cast care with you guys, so I'm not going to um, go over it here. But the cast care is the same for adults as it is for children, except for with children, you've got to watch for the developmental ages of them. They may stick little things down there, so you want to be careful about what toys you give them. Then some of them may need a pressure reducing mattress. So these are all things that you want to be looking for. Um, so be sure you're getting a lot of fluids. You might, if they're having trouble peeing, you might run warm water over their thigh, or put their hand in some warm water. Put them on the bedpan and run warm water over their genitals. Turn the water on, let it run in the um, wherever they're hopefully close to the kitchen or the bathroom, so they can hear it running, and always be watching for signs and symptoms of UTI. So that is that portion. Now let's look at the psychological effects of immobilization. Those were all physical effects. And you can see where there's a lot of interventions that we can do, a lot of clinical significance that we need to do, besides just assess the bone and the bone area, and assess the traction, and assess the cast. We need to assess all these other organ systems. Because they are immobilized, they are usually in one area. Hopefully, you might have them where you can move them from one room to another, which would help with some of their psychological issues. They get an altered perception. You put a cast on a child and they think they're deformed or their arm is gone, depending on their developmental age. Teenagers have a really hard time with cast. Some kids think casts are awesome. My son broke his arm when he was 10 years old, and he thought his cast was just the best thing in the world until he started itching inside. Then he wasn't too happy with it. But, the casts like that are not so difficult. Like if they can get around, they have a leg cast or an arm cast, and they can still move around, that's okay. But when they have a cast or traction or bracing that's going to keep them immobilized, or that they have to wear, like if they're wearing, if they're having to have braces that make them feel like it makes them ugly. A lot of teenagers feel that way, and a lot of pre-adolescents are body image aware as well. And then there too, we have to have physical activity in helping them to develop. They got to have that social activity. They got to be out there playing. They got to run off that energy. They got to learn to handle their anger, and all that can be done with physical play. Some of the stresses on the family themselves are, financially it may be a burden, and it's certainly very stressful. And caregivers strain in taking care of a child who not only needs a whole lot of physical care, but emotional care. They may regress. It may be a very difficult time for them. Siblings have some issues with it too. If they feel like that their poor little brother's getting all the attention, then they're going to be attention seeking as well. So they may feel left out. So there's something that we have to make sure everybody is getting their equal time. In home management, you may need special equipment and things to be able to take care of them. So all these things stress the parents. That some of them have to learn how to work the traction, or how to they have to learn a lot of new things that they've never learned before. So how are we going to deal with this reaction to immobility, the anger, the fright, the depression? Um, how are we going to help with the problem that it decreases their intellectual development and causes regression? You may have a potty trained child that goes back to not being potty trained, or you may have one that you've got had off the bottle for 6 months and he may be crying for his bottle. There's just regression in that. You can see that a lot of times. So, helping them deal with their anger, fright, and depression, of course, is going to take a lot of creative thinking in play activities. Anger, if they can do something, if they've got lower leg casts, they can beat little pegs in holes, they can rip paper, they can wad up paper, they can do upper body activities. Fright, of course, is you may want to be doing some little uh, creative games with them that cause them to feel warm and fuzzy inside, using their stuffed animals or whatever. And of course, to help them with their intellectual side, reading is always a wonderful thing to help develop the intellectual development. Some gaming that's appropriate for their age is also good. And how can we help the family? Of course, you guys have been doing community support resources. We can get them in touch with daycares that will allow them to take their child, so they can have some day off. Um, have them plan their time around so that the siblings get their things, and we can help train them with their home equipment and things such as that. We can also send in a home health nurse. So those are some things that we can do for the family. There's not a whole lot that we as nurses can do about financial situation, but if we send them to the support groups can usually help them with that. So trying to also help them with their environmental stimulation. We can take them out of the room. If we can put them in a little wagon, we can change the position of the bed. If they are in a bed that's up against the wall, you can turn it where they can see out the window. Have visitors come that are the same age. Coloring and drawing is good things for most of the kids. Let them wear their own clothes. Don't make them sit around in a hospital gown if they're hospitalized. And if they're still in the hospital, the parents and siblings should stay overnight with them. The we can also the thing about doing immobilization anymore is, 20 years ago, all immobilized children were in the hospital, and they were in the hospital for a while. But now, because we have better casting, better bracing, better equipment, and these children either are sent home in a couple of days to finish out their traction at home, or their cast works so well that they don't have to be quite so immobilized. So we don't see a lot of immobilization of children anymore, but we do see there are some special disease processes where we do see this, because there's no other treatment that they've got going on. There's a lot of stuff about fractures in your book. I'm only going to cover the one that's unique to the children about the growth plate. Miss Medley's going to cover all the other fractures. Everybody should know from their A&P that the growth plate, the fissile, is going to be your weakest point along the long bones because that's where your bone is growing and elongating. That's how they get taller. It's usually very frequently damaged because it is at the end of the long bones, and jumping and catching yourself can cause damage to that. And a lot of times the fracture in the growth plate's difficult to tell because it's usually a just kind of a crack in the bone. It's not where the bone breaks and you can actually see the breakage through the skin. But it's very critical that we detect it, because if we don't know that we have a growth plate fracture, it's going to affect the development of the child. So we need to treat as early as possible. The cartilage known as fiphus is there. Um, and we don't want to see all these longitudinal or angular growth deformities developing. If we don't catch it early, that's what's going to happen. Once a fracture does happen, that muscle's going to contract around that fracture, and it splints it, which is wonderful that the body can splint its own broken bones to stabilize it. But the bone's pulled out of alignment, and we want the bone back in alignment so we'll have proper growth. Children heal faster than adults because of they have a real thick periosteum. They have a real generous blood supply to their bones because they're growing. That's just a natural thing. And then they have that faster metabolic rate. All those things help their bones heal faster. So a neonate who has a broken femur can be healed in 2 to 3 weeks. And then early childhood 4 weeks, and that same femur break in a later child would be 6 to 8 weeks. And then the adolescent, as they're getting older, is 8 to 12 weeks, which may take a lot longer in someone who is an adult. So that's the only one I want to talk about right now. Like I said, Miss Medley will talk about those other fractures next week. So we have casts that are unique to children, and Miss Medley's going to talk about cast care. There's also a page in your book, box in your book, that's real good about cast care that you probably could look at to get a little bit more information. I'm not going to talk about sprains and strains and all that because Miss Medley's going to talk about. All right, so casts unique to children. First of all, there's 2 types of cast. There are synthetic and plaster. When you have either one and they're activated by water, they are going to produce heat. So both of them will produce heat when they're applied. Your plaster ones are cheaper, and they mold better to the body part. It takes them a long time to dry. It can take them up to 72 hours to dry. And it's a real smooth finish, so kids can ride on it, which is a plus for them. The synthetic is more expensive, but it comes in lots of pretty colors. Boys can get camouflage or dark blue or any color they want that's not hot pink like the girls like to pick out. It can dry within 5 to 20 minutes, but it's really rough, and you can't ride on it very well. It doesn't hug the body part as well. So it depends on the break and how you want to treat the deformity or the fracture in if you want close body part containment or not. So that's something that we need to look at. Then we have serial casting that's done with children. That's unique to children, and it's done frequently in serial casting because of the rapid growth of the child's foot, or rapid growth of the bone, or rapid growth of wherever that is that we need to do serial casting because the cast will get too small. And we want to allow for proper development. A lot of kids are afraid of the cast. Depending on their developmental age, you can do a lot of different things. If they're old enough to understand the equipment and look at the bandage before it gets wet and show them how it works, and they're old enough to process that, that's a good thing to do. If they're younger, you may have to cast their doll or their stuffed animal to show them that that it's going to be okay. And so those are some things that we can do to kind of decrease their fear of the cast. Some of them you're not, when they're neonates, they really don't understand what the cast is, so you don't really have to worry about that. You can cast them and they're used to it, and they don't give you as much trouble, really, as one of your kids that's been out and been active and knows that he can play. It makes a lot of difference. Never use the hot hair dryer to dry your cast. It'll dry on the outside, the inside will still be wet. You'll have hot spots. Um, that you don't want it to be there. As the cast cools off, there still may be hot spots in the cast during that drying process. But once the cast is totally dry, and you should hear a hollow sound when you knock on it, um, if you feel hot spots, that could be indicative of an infection where an abrasion or something might be, and we'll have to cut windows. We don't have to take cast off, but we can cut a window where the hot spot is to see what's underneath it. And that way they still have the integrity of the cast, but you're able to see what's underneath it. Remember that we're really concerned about the distal area of the break, not the proximal. So you always want to check your neural checks are going to be at the distal area of the break. That's where we're concerned about getting enough blood and oxygen and proteins, and make sure that we do the 6 P's right there. So we can check the proximal for irritation of the cast, some redness of the skin in the areas that might be indicative of a skin breakdown. And just because the skin is red all over doesn't mean that it's breakdown. That could just be irritation of something we use to clean them with. But we want to be sure that we're checking that. Our serial casting again is used for is used especially to correct clubfoot in a child. We always should be checking for abrasions and cuts before we cast, so we could leave a window open and we wouldn't have to cut it out because that makes it a lot easier. The cast care again is on page 1061. You can use a circulating fan to help dry and cool. When they come back if they come back to the unit from having their cast, or come back to your floor after having a cast placed and it's drying, it's also hot. So you can use the circulating fan to help dry and cool. You don't want to decrease the room temperature too much because you want your cast to dry. And if you get it too cool, it won't dry. So you can't really, oh, they're really hot, let's pop the thermostat down to 64. We don't want to do that. We want to keep the room temperature at around 70 so that the cast will dry. The spica cast is one that's unique to children. Well, actually, adults can have spica cast too, but we see these more in children. There's a single spica cast and a full spica cast, and there's illustrations in your book of the difference in the two that you can look at. The thing about casts that are the spica cast, it's hard to keep it dry from urine and feces because it's attached to the waist and then it goes down the leg, either both legs or one leg. And so that you've got an opening for urine and feces to come out, but it's very close to the cast. One thing you can do is apply some transparent film like we put over IV sites. You can put that on the cast itself and then onto the skin, where you make kind of a bridge between the cast and the skin, so that when they urinate or they have bowel movement, it keeps the cast dry and it keeps the skin dry. And if you can't get it clean by just wiping the film off, then you can replace the film. A prone position is a lot easier for them to feed. If they're lying on their stomach, you can put their plate down below them and they can reach their plate and they can eat that way. So that way they feed themselves, which is a good thing to help them with developmental things. And they're active in their care, so they're having to do some little exercise of bringing the food to the mouth, and they are more likely to eat more if they're feeding themselves. And it's just much easier than trying to put them in a position that's comfortable for them to eat. Um, and they won't eat as much if they're not comfortable when you're trying to get them to eat. And of course, with the spica cast, it's going to interfere with the diaphragm and the lung expansion. So be sure that you're monitoring their ability to breathe and assess their breath sounds and encourage them to do deep breathing and coughing. If you have a child who, is having a cough, maybe running a temperature, and is crying a lot, or not crying a lot, but maybe not breathing very well, you may be looking at pneumonia. So we need to tell our moms to be careful and watch for that, especially in these spica casts. And I'm going to stop this for right now, and that way we can have better control over how much time we got to watch. So, all right, blue button stop.